What are we talking about today?
I think today we're going to talk about qSOFA.
Okay.
And basically the implementation of qSOFA.
Okay. So you want a little bit of history about Sepsis 1, Sepsis 2 versus Sepsis 3?
Yeah, I think that would be good.
So Sepsis 1 is the definition that came out in 1991. It was a bunch of, and unfortunately this part didn't change, old white guys sitting around a table, and not evidence-based. It was literally people sitting around a table saying, this is what I think the definition of sepsis is. And that's the definition of sepsis that we've used for the last 25 years. And what is it?
An infection causing end organ damage and hypotension.
Not quite, although you got a couple of things to mention. So is SIRS criteria.
Oh, okay. You
in
mean
the
like
setting,
actual,
right? So it's SIRS criteria, 204 SIRS criteria,
Mm-hmm.
which they invented then, in the setting of suspected infection. That was called sepsis. If you had organ dysfunction, it was severe sepsis. And if you had hypotension resistant to fluid resuscitation, it was septic shock.
Right.
So that definition was used from 1991 to 2002. That was Sepsis 1. In 2002, they tried to make it better. They had another group of, once again, almost all white men sitting around a table, and they came up with a new, essentially same definition, because they said, we think this isn't particularly good. We don't really like the concept of SIRS. We can't really define organ failure. We can't do any better. So the only thing that Sepsis 2, which came out in 2002, did is they gave you 21 different things to look at that might be construed as organ dysfunction. So versus Sepsis 1 just said severe sepsis as organ dysfunction. Sepsis 2 identified 21 different things that might have been organ dysfunction. And then 10 years later or so, in 2014, although it was published in 2016, a bunch of people got together again. I'm not going to get into it unless you want me to about why it was a bunch of white men, but it was a bunch of white men, sat around a table and said, we think we can do better. The problems with Sepsis 1 and Sepsis 2, one of the biggest problems was SIRS. And the problem with SIRS is that 1 out of 8 people who die of sepsis die without having SIRS. Then at any given time, 50% of people who are hospitalized have SIRS. So it is not exactly, it catches a lot of people, but it misses an awful lot of things. And so it's if half the people in the hospital have it and 1 of people will die without it, it might not necessarily be what you want. And further, there are issues with the term severe sepsis, because that implies somehow that there's a non-severe sepsis. And when sepsis has a higher mortality than an MI or a stroke or a trauma, there's a problem with that. So group got together a couple of years ago and came up with a new definition, which is Sepsis 3. Difference from other, 2 major differences intellectually from Sepsis 1 and Sepsis 2 are, number 1, that there was actually a definition, and I'll explain what that means, and number 2, that there tried to be a data-driven element as opposed to just people sitting around the table.
Okay.
So if I ask you for the definition of a heart attack, what would you say?
Gosh, I would say decreased coronary blood flow to the myocardium, causing end organ damage to the heart and lack of blood flow.
Yeah, that's a pretty good definition. So what's the definition? This is going to sound strange. What's the definition of a definition?
Something that can explain to someone else what you're trying to talk about.
Yeah, it's that, according to Webster's, it's the essence of what something is. So you actually just did a good job of explaining what the definition of a heart attack is. Is the definition of a heart attack an elevated troponin?
No.
No, an elevated troponin is a bedside test that you look for. So if you think about sepsis, what was our definition for the last 25 years? An elevated heart rate and a fever in the setting of infection or blood pressure. Is that how we intellectually think of what sepsis is?
No.
No, that's the equivalent of a biomarker. So the first thing about the Sepsis 3 definition, which a lot of people get confused, is the definition is not SOFA, the definition is not qSOFA, the definition is not anything you use at the bedside, the definition is an intellectual of what is sepsis, the essential essence of what it is. And so in Sepsis 3, the definition, which is the one thing that I think nobody, for all its controversies, seems to disagree with, is 4 elements: life-threatening, organ dysfunction, secondary to a dysregulated host response to infection. 4 things in there. Life-threatening. So by definition, the old sepsis is now just called infection, and the old severe sepsis is called sepsis, because there has to be, number two, organ dysfunction. If you don't
Right.
have organ dysfunction, you're not septic. So if you have organ dysfunction, and it potentially has a chance of killing you, secondary to a dysregulated host response to infection, which intellectually SIRS is not. So this is not saying that SIRS is unimportant. SIRS is important in identifying infection. It has total face validity. Somebody has fever and a white count, you think infection, that's fine.
But it doesn't intellectually define what we're talking about.
Not only does it not intellectually define, it's actually an appropriate response. So when one moves from infection to sepsis, you still have the same bug. So your have suspected infection is the same. The difference is, how does the body respond? So the body responds initially appropriately to an infection. Having a fever is a good thing. Very simplistically, it's a temperature at which you can survive, but the bug won't. Having an elevated heart rate is a good thing. More cardiac output, more blood flow to it. Having an elevated white blood cell count is a good thing. You have neutrophils that come in to kill the infection.
Mm-hmm.
So almost every part of SIRS is an appropriate response. It is a good thing that your body does adaptively to try to cure the infection. Then what happens when your body tries to adapt and then it can't anymore? And then all of a sudden these things that you're trying to do, your neutrophils are coming in and everything, I'm not going to get all basic sciencey, they start attacking your body. All of a sudden you now have a harmful host response. The things your body is trying to do to help you, actually, you have a bunch of neutrophil influx into your lungs. What do you call that?
Or ARDS.
You have ARDS, right. So what causes ARDS and sepsis? Your own body attacking
Right.
itself. And so intellectually, the old definition was not only not a definition, but it wasn't really indicative of what you had. It was indicative of, well, you're sick. The new definition, again, 4 elements that actually intellectually get you to what the disease actually is. It's the best approximation we have today, and I haven't heard a lot of controversy over it because the concept of life-threatening organ dysfunction, dysregulated host response infection is actually a very useful intellectual construct. But utility of that at the bedside is what?
You're pretty much going to look for the symptoms and signs.
You can give me a number. What's the utility of that at the bedside?
0.
0, right. Because you're not going to, any more than you're going to say, I'm looking at this patient and say, they have decreased blood flow to the myocardium, they've had myocardial necrosis, any more than you're going to say life-threatening organ dysfunction, secondary dysregulated host response to infection. So you need to have the equivalent of a troponin, right? So in a perfect world, you want to say, somebody has an MI, what do you look at? You look at a troponin, you look at an EKG, and you say, based upon these clinical criteria, which don't define an MI, that's what somebody has. So part 2 of sepsis 3 is the clinical criteria used for identifying somebody who's septic at the bedside. So simplistically, do you know what the clinical criteria are? Now for septic shock is a different conversation we can have if we want to, maybe next time. Do you know what the clinical criteria are for sepsis 3 at the bedside?
I know it involves many things, but the things that we've talked about before are altered mental status and respiratory rate.
Nope.
No?
No. So that's qSOFA, and we're going to get to that. But again, you look
So
at
then
the...
I don't know what's in specific.
That's okay, right.
sepsis.
So you look at the 4 things that I just talked about. How do you identify life-threatening? There's nothing that you say. If they have a certain amount of organ failure, they're going to have a mortality of greater than 10%. You're not looking for that. How do we identify dysregulated host response? We don't, because we can't do that at the bedside. So really all you're left with is 2 different things.
Oh, I guess.
Suspicion of infection and organ dysfunction.
Okay.
How do we suspect infection? The exact same way we did before.
Sure.
SIRS is still helpful. Anybody, how do you suspect infection? Fever, white count, anything that you had that you suspect an infection in 2014, you still suspect infection. That hasn't changed at all. However, whatever your personal thing is, I went to school, I suspect this person is infected, go for it. The only thing that's left then is, how do you define organ dysfunction? And in the actual clinical characteristics of sepsis 3, organ dysfunction is actually, if you want to be very literal, is the SOFA score.
Yes, not the qSOFA.
Not the qSOFA score. Do you have any idea what's in the SOFA score?
I mean, it's a lot of different criteria,
Right.
correct? I mean,
So
creatinine, lots of different criteria that would indicate to you, as you're saying, there is some endo organ damage.
Correct. So there are 6 things in the SOFA score, and I don't have this memorized, although I've given the talk enough that I sort of generally have an idea. And it's a SOFA score of 2.
Mm-hmm.
The 6 things in the SOFA score are, let's see if I remember them, P to F ratio,
Mm-hmm.
blood pressure, bilirubin, creatinine, mental status, platelet count.
Nice.
And to get to a SOFA score of 2, any pressure does it. A P to F ratio of 300 does it. A bilirubin of 2 does it. A platelet count of 100 does it.
Mm-hmm.
A GCS of 12 does it. Anything that even makes you ever so slightly sick gets you to a SOFA score of 2. If you have a SOFA score of 2 and you suspect infection, you're septic. You're done.
Mm.
But when was the last time you calculated a SOFA score? Terry, when was the last time you calculated a SOFA score?
Never.
Never. How many people do you know in the ED who calculate SOFA scores?
None. Maybe some medicine residents.
Yeah. So we don't calculate it either. So that's why I'm telling you, basically any organ failure. So there is an actual way of doing it, the clinical characteristics. So the concept is if you have any degree of organ dysfunction whatsoever and you suspect infection, you're septic.
Just to pause for a second. So
Yeah.
the SOFA is interesting that you guys spent time on it to define it, but it really is, you took every organ system and said, well, what is the thing in each of these?
We didn't define SOFA. SOFA's a 15-year-old scoring
so
system.
Then
So
why did we incorporate it, I guess?
So
is the question.
basically, because there's one person on the panel who invented it, and
Okay.
it works, and it's validated, and we don't have anything better. By Sepsis 4 or Sepsis 5, the SOFA score will be out.
Okay.
Because nobody knows it, nobody knows how to characterize it, but it is a validated scoring system. The bottom line is, it's an old, and actually includes things like renal dose dopamine. So when people actually really look at the SOFA score, they say, well, this isn't even something that we do anymore, and they're correct. So it is like 95% validity, but not 100% validity.
Okay.
Then everybody has the concept of the dreaded qSOFA, right? So what do you guys think about qSOFA and the ED, Terry?
We don't buy it.
You don't buy it. Okay. So do you know what qSOFA is?
I think that's what I was saying before.
Okay. So qSOFA, and let me tell you how it came about. It is a screen. It is neither part of the intellectual definition of sepsis, nor is it part of the clinical criteria used at the bedside for sepsis. It is a screen to say who might be septic. And specifically what it was done through a database analysis. Again, unlike Sepsis 1 and Sepsis 2, which were just a bunch of people sitting around the table, it was done by looking at over 7 million charts with the statement of who is going to do badly. And badly was defined as either dying in the hospital or spending at least a couple of days in the ICU. And so what we did, and I really shouldn't say we because I had nothing to do with this analysis, I was in the task force but not part of the group that came together with qSOFA, what the people who can do that complicated chart review can do, is they took the 21 different elements in Sepsis 2, 21 different types of organ dysfunction, and they looked and they said, we're going to do all the fancy math to say what predicts those 2 simple things for badness, death, or at least a couple of days in the ICU. They did not say we're going to end up with 3 variables. They said we're going to see however many variables it'll be. If it's 10, it's 10. If it's 6, it's 6. If it's 21, it's 21. It turns out that only 3 had predictive validity. And those 3 are the 3 things that go into qSOFA. And the 3 things in qSOFA are altered mental status. The truth is, if you actually look at what they did for the database, it was actually a decreased Glasgow Coma Scale. But for the sake of simplicity, we ended up just saying altered mental status of any type, hypotension, systolic blood pressure less than 100, respiratory rate greater than 22. You know why respiratory rate greater than 22?
Because everyone writes 20.
Because everyone writes 20. It's probably a lower number, but it's something that's abnormal. If you have 2 of 3 of those, 2 of 3 of hypotension, change in mental status, tachypnea, your chances of dying in the ICU, dying in the hospital or going to the ICU for a couple of days are astronomically higher. So if you have those, 2 of them, it is a screen that you say, it's a prompt to say, wait a second, my patient has this, I should think about this. And I should really look for organ dysfunction. I should look at their SOFA score, and if they have it, they're septic. Now you might say, as I've heard many people say, duh, right? So if you are hypotensive, you're sick. That's probably a true statement. The biggest advance of qSOFA, honestly, from my standpoint, is we were talking about before is what?
Is this a screening tool?
Yeah, but of the three things within qSOFA, what's the thing that we tend to not notice?
Oh, the respiratory rate.
The respiratory rate.
Sure.
So I think most people would get that if your blood pressure is 60, you are sick, right? A lot of people do not get, even though everybody says they get it, a lot of people do not get that if you are tachypnic, that you are actually sick and you're at markedly increased risk. And so it is a screen, it is a prompt to say, this person has something. What's the advantage over SIRS? Terry brought up before off camera, I'm still going to use SIRS. And the truth is, there's still a tremendous utility to using SIRS. Again, because face validity for infection, what's the single best thing we have? SIRS, fever white count. So if you're saying, I'm going to treat somebody for infection, yeah, you want to look for SIRS, you want to look for fever and a white count. And if they have it, you're going to start treating them. You don't wait until they get septic to treat them. You treat them as early as possible. The earlier you treat them, the better they do. But this is looking for moving beyond infection to sepsis. Now we have a dysregulated host response. Now we have organ dysfunction. Now we have a higher chance of dying than an MI or a stroke or a trauma. Might not be as sexy, but you have a higher chance of dying. So this is a prompt to say, let me look at this. Again, most people get the concept of hypotension. They might not get the other things like tachypnea. What's one of the beauties of qSOFA? No blood test.
Right.
Right. And so you can calculate somebody's qSOFA score in 30 seconds if you're relatively rapid at taking a blood pressure. And you can watch somebody, you can take a blood pressure while you're watching somebody breathe and talk to them during that 30 seconds and recognize whether they're, here or not so much here. And you can very, very rapidly get your qSOFA score, which if it's positive prompts you to look for other things, with the goal being treat somebody faster.
Sure. And again, you're sort of, I think maybe part of the issue is that you're divorcing it from the concept of infection, but as you said earlier, not everyone who dies of sepsis has a proven infection.
Mm-hmm. Correct. And it's important, and one thing which we perpetually hear is, if you wait until somebody has a qSOFA score of 2, people will die.
Right.
And that's correct. And so you're not supposed to wait. You're supposed to treat the patient in front of you. And so if you have somebody in front of you and you think they're infected, you start antibiotics. You don't say, well, I don't know, I'll wait for cultures to come back in 2 days. You say, I think you're infected. I'm going to start. And if you say, I think you're in sepsis, you're not going to wait for the lactate to come back to start the 3-hour bundle. You're going to draw the cultures. You're going to start the antibiotics. You're going to give the fluids, even if you don't have the lactate back yet, because you're concerned that somebody's septic. You're going to treat somebody as rapidly as possible, because for every hour you delay antibiotics and septic shock, mortality goes up by what?
30%?
7.6%, exactly. For every hour you delay antibiotics and septic shock,
it's bad.
Mortality goes up by about 8%.
It's bad.
And so you're going to treat the patient in front of you as quickly as you can. So for people who hate qSOFA, if all you're doing is using qSOFA as a screening tool,
doing it wrong.
yeah, it is a prompt, a value-added prompt, if you will, to say, let me look, I suspect infection by the same way you always suspect infection. Let me look for a prompt for organ dysfunction. You see organ dysfunction? In the setting you suspect infection, the patient has sepsis.
Mm-hmm.
That carries with it an attributable mortality. You treat them right here, right now.
So why does the ACEP and SAM, which is Society of Academic Emergency Medicine,
Mm-hmm.
why do they oppose the qSOFA if it seems like it's just an adjunct?
So I've had extensive discussions with their leadership about it. There's more than one reason. So first of all, it's not validated, right? So SIRS isn't validated at all. SIRS is based upon people just sitting around a table and coming up with it, but it does have face validity. qSOFA is based on over 7 million charts, but it is a retrospective analysis. It's not been validated prospectively in the US. It's not been validated at all in low and middle income countries, which I guess ACEP wouldn't care about as much, but we've heard about a lot. And even since it came out, there's a study that came out in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, that says the NEWS and MUSE early warning systems are better than qSOFA. I didn't talk, by the way, about how qSOFA, in terms of how it does, in terms of predicting, and in terms of predicting how patients are going to do, in terms of the badness, inside the ICU, SOFA and something called the LOD score are better than qSOFA, which is better than SIRS.
Mm-hmm.
In the ED and on the floors, SOFA and LODS and qSOFA are equivalent, and they're all better than SIRS. So, having said that, it's not validated at all. and ASAP is correct in saying it needs to be prospectively validated. That was part of the Sepsis 3 paper. They're also correct in being scared, because way too many people across the world read part of a paper, and a little bit of knowledge is a dangerous thing. And so if you read Sepsis 3 and you read, what are the two new concepts? This definition that I've talked about that nobody can remember, it rolls off my tongue, the life-threatening, organ dysfunction, secondary dysregulated dose response to infection. Most people, that doesn't roll off their tongues. So what do they see that's new in this paper that's been downloaded over 1.4 million times now? qSOFA. And they don't even get the difference between qSOFA and SOFA, and a lot of people don't even know that SOFA previously existed. There's a whole separate paper on qSOFA. There's a separate paper on septic shock, which ASAP also had issues with, which we could talk about at a different time. And they said, wait a second, if people think that qSOFA is sepsis, and you wait until you have 2 qSOFA points, you will kill people.
Right.
And that is correct. And there is a very explicit table that's in there about how you're supposed to do it. That qSOFA is a screen, a prompt. It is not part of the definition. It is not part of the clinical criteria. But I think the combination of the fear that people would stop screening for infection, that people would wait for 2 qSOFA points, and the fact that it's not validated, was enough for ASAP to say, you know what, prove it to me, because the risk, if people start only reading a little bit and start doing this, is astronomical. And so this is one of those things that it's not a simple concept, and you really have to take a little bit of time, not a huge amount of time, but a little bit of time to say, what is the paper actually saying? What does the one figure actually say? And then when you put it that way, qSOFA is not a bad thing. It's a value-added thing. But if you don't take the time and you just work in your local ER and you just kind of say, well, I heard about this thing, there's this new qSOFA thing, and sepsis is now hypotension and change of mental status. And so, the person's not hypotensive and change of mental status, I guess I don't have to treat them now. You'll kill people. So don't do that. Treat the patient in front of you.
Don't kill people.
Don't kill people.
Treat the patient in front of you.
Be a good doctor. Do the right
Treat
thing.
early. Treat early. You don't want to. The best treatment for this comes up on a lot of things. What's the best treatment for a DVT?
Not to get a DVT in the
Not to get a
first
DVT.
place.
Preventing it. So what's the best treatment for sepsis?
To not progress to sepsis.
To not progress to sepsis. So people have historically thought, you start with sepsis, how do you treat sepsis? Surviving sepsis is true. The best treatment is to never get it. And so if you recognize that you have an infection and you treat somebody early enough that your host responses appropriately and your antibiotics kill it, you never develop sepsis. You never develop your organ dysfunction. That's the single best thing. So screen people for infection, treat people for infection. Hopefully they never progress to sepsis. That's the ultimate win.
Yeah.